practice session today. Exactly about 4 years ago, around this time, one of my worst nightmares actually came true. Things that I had read about and really been sort of more aware of, but never thought that I would encounter myself, really happened when I lost a very dear and close friend who worked within this organization for over 30 years. When I found his body in the parking lot where he had committed death by suicide. Since then, we've had 2 medical students and probable another faculty member. So this, what we read about, is not something that is distant from us. We all go through our daily life as we are taking care of people at their most vulnerable times. However, during that experience, besides feeling powerless and the feelings of what could I have done, what did I miss, I also realized the need to get help from people who were more experienced. And I'm grateful that we have this interdisciplinary team of people that really understand that normalizing mental health is just as important as it is to normalize physical health. We are all human. So to talk with us today more about that, especially in this special month of September, which is the Suicide Awareness Month, I have 2 very special people who have spent all their career really understanding and being there for each other and all of us. So just before I introduce them, I'd like to welcome you all again. And I'd like to just request everybody to mute their phones while the speakers are speaking, just out of respect to avoid distractions. We do want this to be interactive, which both the speakers will be helping facilitate. If you have questions, please don't hesitate to interrupt. You can either type in the chat box, which Ms. Judd and myself will be monitoring, or you can raise your hand, which may be a little bit more difficult because we can't see the gallery view, but we'll try to keep up with that. But feel free to interrupt because this is more a shared learning. So with that, I'm going to go ahead and introduce our speakers. We have Tricia Henderson, who is the director of the Center for Student Wellbeing at UTC. She's a licensed professional counselor, and her background includes work as a clinician and preventionist in mental health field. Tricia's professional and personal goal is to live in a zero suicide society, and she's really excited to join us today as we continue to create this culture of well-being in our organization. And with her, we also have Rachel Gearinger, who is the Southeast Regional Director for the Tennessee Suicide Prevention Network. In this role, she coordinates suicide prevention efforts across 10 counties in Southeast Tennessee region. She collaborates with community partners, survivors of suicide loss, and others with lived experience to integrate suicide prevention training and procedures and raise awareness of this issue as a public health concern. They both have provided us with tremendous resources, which will be on our website that we had actually sent you the link, but we'll continue to provide that information. And before I hand over the conversation to Tricia and Rachel, I'd also like to take this opportunity to thank Kim Judd, who has really helped organize and get this meeting up and running, but has also done a tremendous job on our website with the help of Ms. Scott. So thank you both. Tricia and Rachel, it's all yours.
So before we get started here, and thank you so much for that wonderful introduction, and thank you for allowing us to be here and talk about this topic. We're obviously both very passionate about this, and hopefully we convey that throughout this training. I just want to kind of put a disclaimer out there that we are going to be talking about some potentially difficult, emotionally difficult topics, such as suicide. That topic was already introduced, and this can be a topic that is hard for people who may have lost someone to suicide, know someone who has struggled with suicidal thoughts or struggled themselves. And so if you have been through any of those experiences, I just want to say I'm sorry. I'm sorry that you've gone through that. And I want everyone to know that Tricia and I are here for you. We are here to support you. So if you're joining us live today throughout this training, please feel free to message either Tricia or I privately through chat. If you have something you want to just discuss with us privately, you can go down to the chat and you can click on where it says to, you can click on our names and message either one of us and reach out. And we are also going to stay on until the very end if anyone wants to talk about anything that they don't want to talk about with the entire group. And if you are watching this recording and you are struggling with any of the content, please feel free to reach out. We will share our contact information, I believe, at the end of this presentation. And we will also share some resources if you're struggling. So please reach out to those resources. Okay, so what we're going to talk about today, we have 3 main learning objectives. And those learning objectives, the first thing that we're going to do is really talk about suicide as a public health issue. I have a public health background, and I think it's really important. Obviously, you guys are in the health field to talk about suicide, how it compares to different public health issues, and what it looks like in our society in general. So we're going to talk about that, and that will kind of set the stage and the background for this discussion, specifically for those in the medical field. We're going to talk about identifying and recognizing important aspects of suicide prevention, including life promotion and self-care. We're going to go over how to talk to a colleague that you might be concerned about. And then the last learning objective is we're really going to talk about how to improve and integrate mental health awareness and suicide prevention into daily practice. So what do we mean by mental health? So we all have mental health just like we all have physical health. Mental health is a state of well-being where we can recognize our own potential, we can cope with normal stressors of life, we can work productively, we can have, healthy relationships, we can communicate with others in a healthy way. And really, people who have good mental health, we're able to function, we're able to contribute to our community, we're able to do our work well, whatever work that is. And so, there's some different definitions of what mental health means. Freud would say that mental health is the ability to love and to work, or it's the ability to play, as well as all those different things. So just as with physical health, mental health is more than just the absence of illness. So we can, not have a diagnosed mental illness, but we can also, still do some things to improve our mental health. And just like physical health, I know that you guys are in the medical field and you always advocate that people get help early for any medical issue that they have, right? We're really focused on prevention and early intervention. The same thing goes for mental health, right? It's really the same concept. We would never deny someone care for their physical health or say, oh, it's not a big issue, you don't have to worry about this. We want to do the same thing for mental health. So we want to make sure that we're intervening early and preventing bigger issues later on. Tricia, you want to go over this?
Sure. Hi, everyone. I included this graphic just to kind of show the continuum of health related to mental health and mental illness. I think a lot of people have the concept and kind of live in the concept of someone with a mental illness isn't healthy. However, what we know is when someone seeks help and continues on a treatment plan or continues to access resources early, having a mental illness you can live in a healthy space. What we also know is some people deal with situational issues that cause mental health problems, and they may be suffering or be in crisis related to that and not be diagnosed with a mental illness. So seeing this on a continuum, being able to look at it from a perspective of the people you're helping as well as yourself, and kind of having that space of understanding we're going to live in this continuum throughout our lives, maybe even day to day, and how can we recognize within ourselves and with others when we're in the green and excelling, and then also when we're struggling and just in that survival state. And so a lot of conversation and a lot of work that we're doing here at UTC that we've done in the past 6 months, especially with our nursing student, has been focused on nursing professionals, medical professionals, emergency responders who are this kind of living in this continuum, but maybe more around the orange and the red due to COVID and due to circumstances related to the pandemic. So what we know is there's situations we deal with that kind of causes us to jump back and forth on this continuum. And what we're going to talk about today is really recognizing that in ourselves and in others so that we can provide early intervention.
Thank you. So setting the context, specifically when we're talking about suicide prevention, because as Dr. Panda said, it is Suicide Prevention Awareness Month, and this is really, a good month to recognize this and the impact that it has on our communities and also those in the profession that you guys are in. So in the United States, every single year, we lose over 48,000 people to suicide. You're going to see the year 2018 on here, and you might be like, 2018, that's 2 years ago. The reason that we have the year 2018 on here for all of these statistics is 2018 is the most recent year that we have statistics for. The statistics for suicide are always about 2 years behind, actually getting them. So we have over 48,000 people who died by suicide in the United States, and this number is increasing. It's been increasing for the past 30 years. And we know that for every one documented suicide death, there are about 25 people who attempt to take their own life each year. So those are people who attempt to end their life and they do not die from their attempt. And the actual numbers, it's important that you look at this word documented, because there are some situations where it could be kind of hard to tell whether something is actually a suicide. And if you guys could have any thoughts on that, you can either unmute yourselves or you can type in the chat. Think about some situations where it might be kind of hard to tell whether something was a suicide or not. I think everyone's still typing their names and where they're at in their overdose. That's a good one, yeah. So estimates, car accident, yep. Estimates actually, they believe that about up to possibly 30% of overdoses could be actually suicides. The thing about a suicide death is that you have to know what the intent was. Did that person intend to die by their actions? Did they do this, wanting to actually die? And in some cases, like a car accident, like an overdose, it can be kind of hard to tell what actually happened, what was that person's intent, sorry. And so the actual statistics, they believe, are about 5% higher than the documented suicide deaths. And you can see on here the total cost of suicide in the United States yearly is estimated at about $34.6 billion. And this includes the people that we lose to suicide, not those who attempt and, require medical treatment. It's okay. So that's the United States. So let's kind of go from the United States to kind of more our state here in Tennessee. So we know that suicide is the 9th leading cause of death for all age groups, and it is the leading cause of death for youth ages 10 to 17 in Tennessee. And every day we lose 3 people to suicide in Tennessee. And our suicide rate actually for the state of Tennessee is around 17. So that is the number of suicide deaths per 100,000 people in the population. The national suicide rate in comparison is about 14. So our suicide rate in Tennessee is higher than what the national average is. So when we break down gender, you can see this graph here. Males are blue, pink is female, and that's a very, gender conforming, colors here. But you can see this is Tennessee data, and it's showing the number of deaths by suicide broken down by gender. And men, you can see the blue line, the blue chart is a lot taller. Men are nearly 4 times more likely to die by suicide than women. Interestingly, women attempt suicide 3 times as often as men. Anyone have any thoughts? You can either put it in the chat or you can unmute yourself. Why would women attempt suicide more often, but men are more likely to die by suicide? Anyone have any thoughts on that? Men use more lethal means. Good job, Elizabeth. That was first answer, and it was right on point. So yes, men are more likely to use things like firearms, and women are more likely to use things like drugs to intentionally overdose. And so when we're looking at our most lethal means, you guys probably know this, firearms are very, very, very lethal, right? There's less of a chance for a person to stop what they're doing and change their mind, or for someone else to intervene, and there's just a higher potential for damage that unfortunately leads to that person losing their life. So the rate of suicide in our state in Tennessee and nationally is highest in middle-aged white men. And comparing suicide to other public health issues in Tennessee, you can see here I hope you guys can distinguish the different colors here, but this is looking at the number of deaths due to suicide, homicide, motor vehicle accidents, HIV in Tennessee. And the very top line here is the number of suicide deaths. The line below that is motor vehicle accident deaths, and then pink is homicide, and the very teal color at the end is HIV deaths. So you can see that more people are dying in Tennessee by suicide than homicide, than motor vehicle accidents, than HIV. And when we think about having a public health and prevention approach, we put a lot more resources and a lot more publicity into and even laws into stopping motor vehicle accidents. We have certain laws in place. You have to drive with your seatbelt, you can't drive drunk, all these different things. You have to drive safely, and there's a lot more messaging out there specifically to driving safely and trying to reduce the number of motor vehicle accidents. I don't know about you guys, but you drive down the highway. I drive down the highway and I see those, those signs that they have over the highway they always have the clever messages on them about driving safe. We don't have so much of this messaging around suicide prevention, and suicide prevention is also, unfortunately, a more stigmatized issue. It's less talked about than things like, reducing motor vehicle accidents. And so, again, coming from this public health perspective, which I can't help but come at because, I have a master's in public health here, it's really important that we have a comprehensive approach to suicide prevention. And you can see on here, this is sort of a puzzle, and it's made up of all these different pieces. So there are many different approaches that we have to take to suicide prevention. So, we need to make sure we're responding adequately to people who are in crisis. We need to make sure that we have effective care and treatment. We have to, work towards efforts to reduce access to lethal means. So that includes firearms, that includes medications, and things of that nature. We want to increase help seeking. We want to focus on postvention, which basically means recognizing that people are dying by suicide and making sure that we're caring for those who are impacted by suicide death. So we really have to make sure that we have a comprehensive approach to suicide prevention. If you have just one piece, it's not going to work. We need every single piece of this puzzle.
Yes, and I will add to that, Rachel, too, that the connectedness piece is one that we're really having to focus on even more now during a time when social distancing and not being able to connect with people in the same way. I think there's a positive to it. I see it on campus where, you know, students are used to virtually seeing each other and meeting and chatting and texting. But I've even noticed here on campus and within even like our neighborhood that there's so much stress related to seeing people in person, and that connectedness, there's a wider gap now in trying to figure out how to connect with our friends, with our family, with the people socially that we need to be healthy and thrive. So all these pieces matter in different ways, and we see them strained in different ways in different communities. But now I think as a community, we're really seeing that connectedness piece challenged even more.
I do want to add really quickly for this slide. This slide and the image came from the Suicide Prevention Resource Center, which if you are ever, you know, wanting to learn more about suicide prevention, that is an amazing website to learn more about, you know, the theory behind suicide prevention and different groups specifically that we're addressing in suicide prevention work.
Yes, and I think we could do a presentation on each of these specific to your group, to the medical professional group as well, which is really interesting. So we've tried to holistically look at this from a broader scope today, but I'll share some information related to some other trainings to add to these pieces as well.
So speaking specifically about physicians and physicians in training, that is, you know, who we're talking to here in this training. And I think it's really important to highlight some statistics because I think that it really gives a good background for why it is so important that Tricia and I are here talking to you about this issue. Specifically for residents in training, 28% of residents experience a major depressive episode during training, and that 28% is compared to 7 to 8% of similarly aged individuals in the U.S. general population who experience a major depressive episode. So that's looking at people who are physicians in training versus the general population that are of a similar age group. So those residents who are in training are experiencing major depressive episodes at a higher rate compared to the general population. When we look specifically at suicide, every year about 300 to 400 physicians in the United States take their lives. And so this is definitely a huge issue that we need to highlight. The rate of suicide among physicians is higher than the general population. And a very important piece, I want to highlight this last piece because I think this is so crucial, is that physicians who die by suicide are less likely to have received mental health treatment than non-physicians who died by suicide. So what that means is that physicians are less likely to reach out for help and reach out for treatment than non-physicians. And so that's really something that Tricia and I are going to kind of delve into today, and how to change that culture so that physicians and physicians in training do feel comfortable actually reaching out for mental health treatment. This is sort of interesting to me, but I think it in a way kind of makes sense. I think that physicians and physicians in training, you guys are helpers. You do so much caring for other people. And sometimes we who are helpers and we are carers and we are in these fields where we're helping people, we don't necessarily think and look at ourselves as needing help and actually reaching out to get help.
And I'll interject here that what we see, what a lot of the initiatives that Tennessee Suicide Prevention Network is taking on are very specific initiatives for certain groups. So farmers, veterans, and higher education. And what we know and what we see is that if we can target populations based on their needs and their specific barriers, that we can reduce suicide rates. And so a lot of training is about just general asking the question and getting information out there. But we all have been working really hard to target specific groups so that we know that we can provide information and really kind of move the needle on that for each one of those groups. And Tennessee Suicide Prevention Network is that statewide initiative that's working on those specific groups. So today we've tried to focus in on that piece too.
Yeah, and that's a good point. We also have a first responder suicide prevention task force. And so, like I said, it's a lot of these fields and these professions where people are caring for others, and they are, really, in some of these emergency situations, and caring for others and not necessarily looking back at themselves and saying, okay, I need help too. How do I get help? And going through that whole process. So we also have a little bit of data specific to COVID-19 and this whole pandemic. There's not a ton out there because, as we all know, this is new to all of us. We're all going through this, as it's happening, and we don't necessarily know what what the impacts on mental health are going to be of this pandemic. We're kind of figuring that out as we go along. But this survey was released by the CDC, and it included about 5,000 U.S. adults who were polled between June 24th and the 30th. So that's just, a 6-day period. And about 40% of these U.S. adults who responded during this time period reported experiencing adverse mental health conditions. And this was specific to caregivers, unpaid caregivers, and young people. But overall, about 41% of respondents reported that they had at least one adverse mental or behavioral health condition, which could mean symptoms of anxiety, depression, or post-traumatic stress disorder during this time period. And nearly 11% of those who responded reported having seriously considered suicide in the month before participating in the survey. So we know, another piece of this survey was that 54% of respondents reported having at least one adverse mental or behavioral health symptom, and that was specific to people who were essential workers. So we do know that COVID-19 is having an impact on people's health. What that looks like isn't exactly clear yet, because again, this is really new for all of us. Tricia, I don't know if you want to add anything on there.
Oh, I'll just say that there's a lot of time and energy, I think, in the mental health field, trying to think ahead. We are in the moment looking at the impact on our community mental health, but then also looking at post-COVID and what's going to happen after we're kind of out of the moment of crisis and taking a breath. I think a lot of people realize that that's when you start to slow down, and that's when we start to kind of have those feelings of like, we're not in the moment of crisis any longer. We're able to reflect, and we're trying to get ahead in that space too. So there's a lot of conversations about being in the midst of the pandemic and then after the pandemic, looking at that as well.
So we're going to talk about risk factors that are specific to this profession and this field and people who work in this field. And so risk factors, when we talk about suicide prevention, these are going to be things that are specific to a person or part of their environment that are going to increase their suicide risk. Now, you might look at these and be like, okay, I see some of these in myself. This does not necessarily mean that, if you experience one of these or even several, you are going to go on to die by suicide. That's not how this works. This is kind of just context and things to think about, and some of the factors that can kind of come together and contribute to a person having suicidal thoughts. So specifically for this field and this profession, a lot of job stress. You guys probably know this, and I'm preaching to the choir. and a heavy workload. And this can result in things like lack of sleep and just, constant stress, and your body experiencing that constant stress is really can be detrimental. And we'll talk about burnout in a second. Depressive disorder, that is another risk factor. We know that people who have mood disorders, particularly bipolar disorder or depression, are more likely to die by suicide. So their suicide risk is higher. In the medical field, a person may have better access to lethal means and greater knowledge of lethal drugs, which is another risk factor, because access to lethal means in itself is a risk factor. And a person who has, perhaps greater knowledge of what combinations would be more likely to lead to death, that is really a risk factor in itself. There's also a big stigma. There's really a culture of self-sufficiency and really not reaching out for mental health issues in this field. And so some of that stigma is institutional, and it is the entire culture in itself. And unfortunately, what happens with stigma is that we can then turn that institutional or cultural stigma into inward to ourselves, and we will start to embody that stigma. And so that's where it really becomes dangerous, and it can lead to things like not reaching out for help when you need help. And there's also perceived or real barriers to mental health treatment that are specific to folks in the medical field. So this could be, not having enough time. This could be, feeling like there's not access to treatment, or worries about confidentiality, or worries about, how this will affect your reputation, or will people see it as a sign of weakness. And also substance use is another risk factor. Tricia, do you want to keep going forward?
Did it change? Did it change, Rachel, on the screen?
Yeah, okay. And so this, I'm not going to go through all this, but this really just shows how complicated suicide is and kind of how this can happen. We all have different risk factors, and I talked about some of the ones specific to the medical field, but there are also ones that, everyone can have on top of those risk factors. And then, something can happen in a person's life, and we call this an acute risk factor. It can be, some sort of crisis in a person's life, and this can make a person feel hopeless. And this is kind of the common pathway to suicide. Just a quick note on burnout. So burnout is physiological, psychological, and physical exhaustion that can be caused by persistent distress and persistent stress on the body. And burnout is something that is a risk factor. And this affects almost half of physicians in the country. Here are some signs and symptoms of burnout, so you can recognize it in yourself and others. It could be things like having a negative attitude towards patients, having lack of empathy towards patients, high rates of alcohol use and depression, reduced cognitive functioning. Burnout can even affect your ability to perform your job, compassion fatigue, and different signs like that.
Thanks, Rachel. I'm going to pick up here and move on to just common myths. And hopefully some of this next piece of it too will answer the question that was posed in the chat about stereotypes and stigma. And a lot of the times we find that really just buried deep in this conversation is a lot of ongoing myths related to suicide. And I won't read every one of these, but just understanding that we are not going to plant a seed if we talk about it with our colleagues, our friends, our family, our clients and patients. We can't plant that seed in someone's mind. What we find as we address this in a public health perspective is that the more that we talk about suicide prevention and mental health awareness, that we can make an impact and get people to help earlier so that they can seek treatment and move on and live healthy lives. And so challenging these myths that once someone has decided to complete suicide or die by suicide, we can't help them, that they're attention seeking in some way, and that there's no warning signs. And what we really know is there are pieces that we can put together and have a larger conversation around warning signs and intervene earlier. So just kind of discussing these are not specific. These are what we teach in almost all of our trainings, but just seeing people change in different ways. And it's hard to know because we have the person who's a colleague or a friend, and we don't always know what's happening at home and in different scenarios. But if we just are generally aware of different changes in energy, appetite, sleep, behavior, even if they were optimistic people and had a certain life outlook or view, and suddenly that's changed, or interests or disinterest in hobbies or their faith, things like that can be a lot of these warning signs that add up. And I think one of the barriers in all of our conversation around suicide is I can't give you a perfect formula to know when to talk to your colleague or know when to address it for yourself. I can't tell you what that's going to look like for each person. But what I can say is if we take warning signs, if we take risk factors, if we take our general knowledge of who that person is and who we are, and then if those things are adding up to that gut feeling that something's wrong, or I don't know what's happening, but there's a concern that we're having, then asking the question is really important. And I'm going to get to that piece of how we can ask the question. But as I think about that, I think about it in a way of even our approach at UTC and the work that I do. It is not just telling the mental health staff or the medical staff on campus that it's their responsibility to prevent suicide. It's taught in a way where it's everyone on our campus's responsibility to have a conversation in this with our faculty, with our students, with our staff. So that's a really important perspective and shift that has to happen in a group or in a community or at a hospital, is that it's not just going to be put on one group of people. And this is an approach that has to be from everyone's perspective. And so I think about, and when we train people in your practice, it's not just a certain group who's getting a training on suicide prevention. It might be the front desk staff or people, the nurse practitioners and the doctors, and everyone in that group who has that training and ability to intervene. And I think that's really an important piece of the approach. So just some tips for staying healthy. I think remembering that prevention is health promotion. If we're getting in front of something, and the further upstream we can go, the better, right? And so we know that with a lot of different health promotion related to smoking or traffic safety and things like that, we have to get ahead of it. We can't be reactionary in everything that we're doing in the approach when it comes to mental health issues and suicide awareness. Also, just generally, getting enough sleep, eating well, exercising. But I don't want to leave it there because telling you all the wonderful coping strategies that you can use, like meditation and deep breathing, and the things that work for me may not work for you. So I want to say and recognize that it is important to have healthy coping skills and to really exercise those skills when you need them, and to take a moment of the day to take care of yourself. However, I think there's a deeper piece to the stigma and the conversation that we're facing around suicide and mental health. So just being able to give yourself permission to recharge and take time off. I worked in a space one time when it really was the culture that it felt like it was not okay to take care of yourself. And I worked with mental health. This was in a mental health setting. So it felt like it was opposite of what it should be. And I bought into that. So now I make it an effort to really think about, like, what does staff and in our space need? What do they need time off? Do they need to be able to work from home? Do they need more flexibility? And I understand that there's some settings where that's not always going to work, but we also have to change the culture of that we have to be there to control everything. And then if we're not showing up 24/7 and carrying our work home with us, or on call constantly, then, you know, we've kind of set the bar at a place where we're really not balancing that mental health piece of it. So that was a conversation with our group, is the conversation around what are our expectations around self-care, and then what are our expectations around our just general professionalism and being on call and being accessible 24/7 to our work. And so we made some decisions about that. Learning how to say no can be a big piece of it. And that's, again, about that conversation around where are we setting the bar for ourselves and each other? And then, is it okay to say no? Is it okay not to pick up this shift? Or is it okay to say, I need this holiday to travel and see my family? That's part of my personal health plan. Being able to connect and be around others. And working in higher ed, you know, we see a lot of students who aren't traveling as much right now. So that might look different for them in this space of not being able to travel home, but connect in other ways. Also, just learning how to recognize signs of stress and depression in yourself and seek help, and reaching out to colleagues for assistance and support, changing the culture around that. It being about sharing experiences may help others in other situations. So the support of colleagues can be a great source during difficult times. And I'm going to share a resource that I found about peer support that's really important, especially with medical professionals and first responders, and what that may look like. So just talking with a colleague, again, if you see the signs, it's very important that we reach out. Just that simple action promotes connectedness. The simple action of someone being seen and heard in a space where they are in the darkest place of their lives can be that glimmer of hope that's needed to stay alive. And we have a lot of stigma around having that conversation. There's a lot of fear around, if I talk about suicide or if I tell them that I've noticed this, are they going to blame me, or you know, whatever that stigma is for you or for everyone involved. So what we really encourage is that conversation is about hope. That conversation is about feeling connected and seen. And I can say in my work and outside of not just being a clinician, but in my family group, in my friend groups, and the community in general, I've found that the more people talk about it and the more often I can say, hey, I really care about you, I've noticed these changes, people are often very relieved to have been seen, and they want to feel like someone's noticed them. And that could be a big game changer for someone who's thinking about taking their lives. And so in that moment, it's about being present and listening without judgment. And that can be really hard when we're talking to someone we care about and we love and we respect, who may be our mentor or whatever role they take on in our lives. But just being present in that moment is that, again, that piece of hope that can really provide what's needed to move that person forward. And sometimes that self-care afterwards, after that conversation, is just as important as what you just gave to that person. If someone talks about suicide, you know, you can talk about, I'm sorry you feel this way. Can you tell me more? What do you mean by this? And peer support may help people seek formal treatment earlier. A lot of studies show that people will live with a mental health problem or even a mental illness and go years before they seek treatment. So it's really important. And this piece is that peer support can offer that earlier. And in working with people who are seeking their degrees, continuing education, things like that, it's really important, because what you don't want it to do is for that to escalate to a point where they're losing relationships, their ability to maintain their grades, to make it through school, all of those things. If we don't seek early intervention, what we know is the negative consequences of really living in a space and not taking care of yourself can have can really impact other areas of our lives. And so I feel like whenever I encourage people to have that conversation, it is a lot about, if we intervene early and we have that difficult conversation, then we might be really saving them from other problems in the future. Rachel, did you have anything there that I missed? Okay. So ways to get to the question, and a lot of people think like, well, you're asking me to ask a question. I'm not just going to walk up to someone and say, hey, are you thinking about suicide? You can take a softer approach and talking about what you're seeing, or asking them if they feel hopeless, or does this situation feel hopeless? Asking them to clarify. Do you ever feel like just giving up? Or what does it mean if you just give up? Starting there and then getting to the question is really important. And I do this in a lot of ways, whether it's social media, where I see people that I feel like I might need to intervene. Used to, whenever I was at the grocery store and I ran into people, or I noticed their conversations, you can have this in various settings with people that you know in various levels. We think that we have to be their best colleague or their best friend or their closest family member to have this conversation, and that's just not true. Anyone can do that and be in a space where they can help each other. And what that looks like will look different based on your relationship. So just fostering a culture of help-seeking behavior and care. I've found online, as I was doing some research for this, there was a space where someone said mental health takes a village. And it really does. This is a community conversation. And so if we encourage and model support for colleagues, if we reinforce the request for sick leave, if we're promoting a healthy communication and positive feedback and praise, that can make a big difference. Also, increased resources and increased amount of time people have to take care of themselves promotes that self-care we're asking for. So looking at it from across the board of what are we asking from the people that we're working with, and how are we helping promote their access to resources and their access to that time for self-care. Here, on this last bullet, I found a training that I thought was really interesting that you may want to research, but it was about stress injury, specifically related to COVID. And it was Dr. Tricia Watson with the National Center for PTSD that put it together. And it talks about that stress injury and that medical professionals may encounter and how they can address it with themselves and others. So I think it would really be a complement to what we're talking about here that's very specific to her topic and theory related to stress injury. Another piece of it is, if we're looking at a wellness toolkit, I want to go back to that conversation I had where I didn't want to just come on here and tell you to go and do some deep breathing and it was going to solve the problem. We are at a place where the conversation is a little bit deeper than that, or a lot deeper than that actually. So it's about how we're treating ourselves, how we're treating the conversation of mental health and suicide awareness, and how we're treating each other in relation to that. So all of that holistically has to be modeled in a space where we're challenging a lot of the barriers and the stigmas that we're seeing specifically. And so a lot of work that we're doing, and that Rachel and I have been doing just here specifically in our community, is helping organizations and businesses look at their policy. And a lot of times policy change will help move this conversation forward in larger organizations. But even that, just having a conversation about how you're promoting hope and care in your space. I really liked the UT College of Medicine. You had a really great website with suicide prevention resources, that wellness model, and that can make a big difference. on it, and included the well-being index. And so just taking that and checking in, using these online tools that we have. Also practicing self-compassion. What does that look like for you? Sometimes that's about forgiveness, of mistakes we felt like we've made, forgiveness of doing or saying the wrong thing at the wrong time. A lot of that is just kind of facing those fears that we have. Also providing support for each other and asking the question, showing that you can and you will, and that's a value of yours. Challenging the stigma. What are the stigmas that are keeping this group specifically from seeking help? And I think there's a lot of work that we have to do in this field. We seem to have done a really good job with specific populations and continue to do that. But in this model, as we look at first responders and physicians, nursing students and nurses, what are those barriers? Is it about perception of not being able to do your job well, fear of losing a license, not understanding mental health and confidentiality and what that might look like, not understanding resources? And so we've been doing projects with local hospitals, and one of the local hospitals, they have a huddle every morning, and one of their leaders talks about mental health and well-being on a regular basis, if not daily, from what I've been told from one of the people at that organization. And even that culture of that brief moment can really change and sway the conversation in their organization. And they have really been highlighting mental health and specifically suicide awareness at that hospital, and really trying to track the impact of what they're doing. And it's interesting to see leadership, the influence of leadership can really be one of the biggest examples of how to take a barrier related to help seeking and getting care and taking care of yourself. So that's, I think, an important example. Also restructuring that kind of inner playlist of negative thoughts, and here comes the counselor in me. But those cognitive distortions that we have about who we must be, who we're striving to be, what that looks like. And I'm not saying that we have to take all of that and make it into something completely different, but if we restructure it to something that's a little bit more realistic. Sometimes I hear from people in the mental health and medical field that they feel like they're not doing enough, that their contribution isn't enough, that there's people who are doing more, or they're not helping like they should, that others are judging their work. And those feelings, that constant playlet, that tape in our head, if that's what we're saying to ourselves, if that's what we're doing, then how can we shift it to a more realistic place and live in a place where we acknowledge the negative? Yeah, there are negative things that are going to happen throughout our day. There are things that we're not going to do as well as we would like, but how can we restructure that to highlight the positive and really have that growth in that space? And so acknowledging that our thoughts and our feelings and our emotions play as big a part in our health as other areas. And so highlighting those on a regular basis. What are my thoughts? How are they impacting me? What are my feelings? How are these emotions either playing a part in my daily life, or how can I address them in other areas? So do I want to take time to seek counseling and spend an hour working on my mental health? Or do I want to go, and is there another way that I can kind of be there in my thoughts and in my feelings and in my emotions and address them so I am healthy, and it's a part of my health plan on a regular basis to be aware of that. I know that it can be really easy to live outside of those emotions and those thoughts and feelings, and so just giving some time to that can be a very impactful part of your health plan and really help with that piece moving forward towards prevention and education and early intervention. So resources, I wanted to highlight these. There are resources that we have available to us 24/7. The crisis text line is where you can text with someone and seek help. And it's not just for suicide awareness. It can be talking to someone about life events, situational things, relationships. So it's a really good text line. You can use it. It has some really great data on it where you can see, just trends and keywords and things like that if you're interested in that piece of it. But just for daily life, having someone who's disconnected from us personally, disconnected from us professionally, it can be nice to have a sounding board, and that text line can be that. The Suicide Prevention Lifeline, this is the number that will be turning into the 988 for mental health. We're getting a 3-digit number. And so until that happens, this is our emergency number for mental health, anywhere you're at. And then in the state, we have a crisis text line. Now, I did some research on what you have specifically available through the university and through your program. And so there's LifeBridge, there's the Wellbeing Index that I highlighted earlier, just being able to go there as a resident and kind of get an assessment. And also the initiatives that you have related to the LifeBridge line. It's a confidential space where you can access a counselor. And then using your health benefits through Cigna, and also confidential and free counseling services through the Next Gen EAP can be really important for faculty and staff to assess where they're at and see what needs they might have related to seeking additional resources and providers in our area. And let's see if we go. So I'm going to end there. I know we've got 4 minutes. I'd hope to leave a little bit more for discussion, and I apologize. But Dr. Panda, did you want to highlight the next slide, and then we can go into the question and answer piece of it?
Sure. Thank you, Rachel and Tricia, and thank you all for listening. I think a lot of information was a good reminder for us that while we don't try to intentionally think about these things, the culture is around us and within us, and we have to be intentional about preventing it. I started off this introduction with a very personal story of my own experience of losing physicians to the tragic death by suicide. So I think it is important that we continue the good work that we are doing within our institution through the Wellbeing Task Force and the Resident Advisory Board, and then also through the student-led initiative, because we have some students here. I wanted to also highlight what you have heard from Tricia and Rachel about self-care. We often think about it as selfish. However, just point out that we can't give to others what we don't have ourselves. We've all in the medical profession and the nursing profession, and now even in the allied health professions, taken the Hippocratic Oath, which is a very solemn oath, and it is timeless. However, the current healthcare system really asks of us a lot more than when the Hippocratic Oath was penned. What we require now is a partnership within our healthcare system and the healthcare givers. So I wanted you to just be aware of this oath to self-care and well-being. Many of you new interns have already received this when you were during your orientation. It is going to be available on our website, but it is really things that have been adopted internationally through the World Medical Association and the Geneva Foundation, and something that really gives us permission to not become altruistic in a way that is pathological to ourselves. Thank you for this platform of having this discussion, and we will continue this discussion within our organization. Given the last minute that is left as we continue, if there are any questions, one issue that I want to highlight as a takeaway today is that role of connectedness and to reach out to somebody. I think it has been researched very well. There's a lot of evidence around that, and actually there's a lot of evidence from the Army and other services literature, what is called as battle buddies. Just having a buddy check with somebody on a regular basis really builds that connectedness and makes the person feel cared for and seen. So what I would request you all to do now, many of you already may have a buddy. If you don't, and if you can reach out to somebody that you may not know, maybe from another program, just send them a message of gratitude privately. Let's take a minute to do that on the chat box, to send each other, just one person privately. We don't need to see that in the whole chat box if you don't want to. For those of you who are in a group, you may want to just do it amongst yourselves. While you are still typing, does anybody have any questions or any comments that they would like to add? With that, Rachel, Tricia, Kim, anything else that you would like to add?
I'm just grateful for your time today and to be invited to speak with this group. And as we continue to help spread the message and promote suicide awareness and mental health, please let us know how we can help with your organization or provide just support in any way possible.
Thank you all. Have a good rest of the day and rest of the week. And stay safe and stay healthy.